I'm Keith Esrick. I'm with the Cure Starts Now. I am glad to also be joining in this discussion and presentation of Dr. Carl Koschmann's work put on by the Musella Foundation and Al Musella. And obviously what we're talking about is DIPG and some of the updates on what's going on, but also in particular having to do with what's going on at Michigan and his work here. For those of you not familiar with Dr. Carl Koschmann, he is a very collaborative researcher in the field of DIPG, has been involved in research there at Michigan Medicine and Mott Children's Hospital for how many years now, Carl? Probably about, what, 5, 6? Or you
yeah,
more than that? Just
I started training here in 2011.
Okay, all right, 9 years. So we're very glad to have his help on many different areas, and he has some of the most groundbreaking elements of the DIPG. And so without that, I'll let you go ahead and run with it.
Thank you, Keith, and thank you, Al, for the opportunity. This is exciting to be able to talk to the audiences that you guys have gathered, and sounds like this is being shared through through the Zoom meeting and also through some various Facebook posts. And so excited for the opportunity to speak to everyone, and look forward to being able to share what we've found in the last couple of years, as well as give some updates, and then look forward to answering questions and having a conversation at the end. So what I would like to cover is honestly, a lot of the topics that come up when I take care of children with DIPG or the related overarching diffuse midline glioma in clinic, and be able to disseminate some of the information we've learned here and my understanding of current research in the literature to make it more accessible to patients who don't follow with me. I am a pediatric neuro-oncologist. I see children with essentially just pediatric high-grade glioma, including DMG and DIPG in the clinic, as well as that's what my lab works on, both basic work with cells and mice, but also with human samples. Here's an outline of some of the things that I'd like to cover today. We'd like to spend a little time breaking down the acronyms that have popped up in the last year with DMG and the confusion between DMG and DIPG. I'd like to handle that. This presentation will actually really look at DMG and then sometimes specifically DIPG. Because the histone H3K27M mutation is seen in a majority of patients in this patient group, we're going to take a little time to explain that, and then talk about the decision to biopsy and what is learned from that. We're going to go through a couple current treatments, investigational treatments, studies, as well as what our current understanding of the prognosis is for DIPG and DMG. And then we're going to get a little bit more into our research, including a fair amount of time focused on the promising agent ONC201 in terms of what we've covered in our lab, what we call preclinical, and then our experience clinically, both here at U of M and then abroad with some of the other institutions that we collaborate with. Another project that our lab has spent some time on is liquid biopsy, and you've probably heard this term, but we'll talk about how we've used it for diagnosis and treatment response monitoring in this patient population. And then just touch a little bit at the end about some trials, future trials, especially related to ONC201 and where they're at in development. So to start, DIPG is a term that probably everybody in this group will be aware of. It stands for Diffuse Intrinsic Pontine Glioma. And it's really a high-grade glioma, sort of a cousin of GBM, if you know that, in adults, but specifically in the pons, the brainstem, the middle part of the brainstem. And it is a phenomenon that we see almost exclusively in children, although there are some adults who develop this. And by definition, it is a radiographic diagnosis. So you get an MRI, or in sort of older days, a CT. And if the tumor takes up at least half of the pons and it's growing from within the pons, that's enough to meet criteria for DIPG. And that's why for so long we've really hesitated to biopsy, because we don't need to know what we're up against and what treatments we might try just based on the MRI. That the intrinsic means that it grows within the pons. The diffuse means that it grows through normal cells. So right in the middle of this white stretch of tumor over here is normal pons doing things like coordinating speech and swallow and movement in the body and sensation. It's a true highway connecting all of the important functions. And so it's really a devastating diagnosis because of the functions that can deteriorate as the tumor grows. So we see it mostly in children 5 to 9, and it's rare compared to some adult tumors, but it's not all that rare in the pediatric world, and especially the pediatric brain tumor world, about 1/10 of pediatric brain tumors. And we know from following this patient population that it has a very tough prognosis, and very few patients survive beyond 2 years. So just to clarify, and as we prepare to talk about DMG, DIPG is really not defined by genetics. You don't need a biopsy to get this diagnosis of DIPG. Now we move to DMG, and this is something that has really changed in the last few years, that when you have done a biopsy of a tumor in the midline, so that's on this schema over here, you see the brain. When we talk about the midline, it's the middle parts of the brain. So the thalamus and the upper part of the brainstem, the midbrain, the pons and the medulla, or the spine for that matter, which isn't really shown but connects to the latter part of the brainstem. These tumors we now know, for if you have a high-grade glioma in any of these regions, they are biologically very similar, and enough so that the pathologists, along with the strong support of the research community, started to came up with a new diagnosis once you biopsy those to say that it's a diffuse midline glioma. And you really need that biopsy to reach that. And so what this means is you have a grade 2 to 4 glioma. It's a tumor that infiltrates into the healthy brain. And then it can be in any part of the midline. And then just so that, to make it clear, a DIPG, which you had just diagnosed radiographically, is a type of DMG. So if you have a Pontine middle of your brainstem tumor that then gets biopsied, you could say you have both a DIPG and a DMG at that point. It's just a type of DMG. And again, we're seeing DMG in younger patients, but now you kind of extend it once you start to think about thalamus and spinal cord, more like age 5 to 20. And again, the prognosis is very tough. It's not a lot different from DIPG. And again, this biology is really driven by this mutation. It's called H3K27, and we're going to talk about this on the next slide, I believe. So we see this mutation in over half of these patients, and in 80% plus of DIPGs. And so now if you have a diagnosis, that's a defining feature. You have a DMG, whether you have the H3K27M mutant or wild type. And we can now figure this out. Used to take us, we had to do sequencing and it took weeks to figure this out. Now most big centers have a stain where you just stain the cells, and within a few days you can say whether it has this histone mutation. So let's talk about that histone mutation, but I just wanted to make it clear to everyone that distinction of DMG and DIPG. You know, a lot of foundations and clinical support groups are based around DIPG. These tumors are so similar, are going to be increasingly treated together, that I think the research community is really rallying around this DMG. And so increasingly, we're going to probably be thinking about these as partners, and maybe partnering just from a sort of a, research and clinical and foundation, and you could imagine conferences being more centered around DMG in the future. So what is this histone mutation? This is going to be the hardest slide, I think, to follow in this talk, but I'm going to try to go through this and bring everybody up to speed, because it is an important thing to understand when you're thinking about the biology of DIPG. So at its very basic, DNA is the template that all cells follow, both tumor cells and healthy cells, for their behavior, how they do, decisions to divide, to grow, to die. And you can think of it kind of as a book that the cells read and then decide to build things out of that and make decisions about whether that cell's going to, what behavior it's going to have. DNA is organized around this scaffold called a nucleosome, which is made up of balls of proteins called histones. This is going to be very important for DIPG. If you think about this book, this is sort of maybe the, the binding of the book. It's going to keep that DNA organized, and it's also going to help guide the book in terms of what chapter you're going to read, which genes you're going to actually express and use. So each histone, the ball of this scaffold, has a tail. There's these tails that come out made out of protein that are part of this nucleosome, and these are very important tails for all cells, but especially DIPG cells, and this is why. The actual protein that makes up this H3, this chunk of the nucleosome, has all these spots, these important Ks, these are amino acids called lysine, that are important. There are about 80 different ones, but one that's maybe the most important is 27. It is a key signaler to the cell as to whether or not you're going to pay attention to this DNA that's wound around it or ignore it, close it up and not listen to it. It is a master regulator. So if you have a mutation in the gene that encodes this protein, you're going to have a bunch of DNA that now is wound around a rogue nucleosome that's going to behave a little bit abnormally. And so if you have a mutation in either one of these genes, this K just became an M, and it just did a big change in how the DNA is going to be read or not read. So this K27M, we believe, only can do that kind of misbehavior, that critical misbehavior that switches cells over into tumor cells in the right context. So if this were to happen in your adult skin cells, we don't think it would be the setting to set up a tumor in your skin cells. But if it happens in your brain stem, as your brain stem is dividing and developing an age 7-year-old kid, that is just the right setting for that mutation to cause problems. And what it does is it causes those cells to behave more youthful, we'll call them stem-like cells, and also divide more than they would otherwise. And you can imagine these cells now, these glial cells starting to become more tumor-like and turning into official tumor cells once they pick up extra mutations, then growing and dividing. And at this point, they're no longer listening to the normal signals to slow down. So that's very heavy. You don't necessarily need to have grasped all that, but we're going to talk about K27M, and I wanted to give everyone a chance to hear that, my best shot at explaining it. Why do we care about K27M? Well, we now know that K27M, if you have it, your tumor behaves very differently than if you don't have it. And so this is a survival curve, and if you haven't read these, the way that they work is at the beginning. So this is maybe we could say high-grade gliomas in children. At the beginning of time, here 0, 100% of them are alive at their diagnosis. But as you move towards 20 months, many of them don't survive, unfortunately. And especially when you get out to 36 months, less and less surviving. That drop-off is how aggressive those tumors are. The faster it drops off, the more aggressive. And you can see here, wild type, these are pediatric high-grade gliomas that don't have the histone mutation, more children surviving a little bit longer. Obviously still a very tough diagnosis, but you have some possibility of longer-term survival. These patients with histone mutations, H3.3 or 3.1, they have a really tough and narrow window of survival. And so because that's been such a key prognosis step, that's why it's built into the diagnosis right out of the gate. That's why our trials are really gathering. We need to know that, and we need to stratify patients by that. And we really need to, if possible, target our therapies to that mutation. I'll just take a quick moment. This is work that came out of the DIPG consortium that looked at a large number of patients with DIPG, and they really needed to be confirmed, not just by their institution that they had a DIPG by imaging, but an expert radiologist reviewed. And once they did that, they put all that together, and they put together the best estimates we have. And unfortunately, the median overall survival for MRI-confirmed DIPG currently is under a year. So this is obviously very tough. There are patients that live longer, and some of the things that predicted that were being a little bit younger and having prolonged symptoms. Means you didn't go from no symptoms to having symptoms of DIPG at diagnosis quickly. It maybe lasted over some months. So maybe a little bit more likely to have a more prolonged course at that point. And just for comparison, if we look at our thalamic, the DMGs that are in the thalamus, that overall survival from what we can do from some meta-analyses that's a little bit better, but not a lot better, about 14 months on average. This is average. There are patients that do better and worse than that. What helps? Radiation therapy is honestly the most established thing that we have. It does, usually we do it over 6 weeks, right at diagnosis, and it does definitely improve survival and improves quality of life and symptoms. So that's more or less done in most patients with DIPG and DMG for that matter. And then the next best thing that we definitely have data for now is that doing a second course of radiation at the time of progression does appear to help. This has now been shown at a number of centers at a short 2-week course of the recurrent tumor, especially if it's been a little bit longer from diagnosis, ideally about at least 6 months from the last radiation, and it can be done safely. That does seem to help. And so this is what we're doing as our standard of care here. And so we have radiation, we have reirradiation. And then everything else is experimental, but we'll go through there. And obviously there is a lot of enthusiasm and interest for what those experimental treatments are. Let's just talk quickly about biopsy. So why do we offer biopsy? And I think, if you have the diagnosis, it's DIPG, the only thing you have that works is radiation. Why would you put your patient or your child at risk by offering a biopsy? It's a good question. I think it's sometimes the logic that has been enough for families to avoid biopsy. We certainly don't fault families who make that decision. This is some of the points that I bring up when I talk to my family. So we would like to know, even though we have that radiographic diagnosis, if it's a DMG, if it has that histone mutation. And why would that be the case? This was a paper that just came out of St. Jude, where they looked at patients who had DIPG that was maybe a little bit atypical. Maybe it didn't take up 50%. Maybe it was a little bit outside of the brainstem. Otherwise, we thought most likely a DIPG, but just a little atypical. And that group, up to 30% of those patients did not actually have a DMG with that, sort of what we think of as the true biology of a DIPG. And then just at our own institution, even patients that had typical appearing DIPGs, about 1 in 10 when we biopsied, they were a different tumor. So to me, this is some of the most compelling reason to say, we might treat your child differently if we knew that, and we would maybe have a very different diagnosis. This is a data we published last year showing of a patient who had a DIPG by radiographic, was given that diagnosis when they were referred to our center. And we did a biopsy, and it was tricky, but we sent this for methylation testing at the NIH. And what we found was that the tumor was actually indeed biologically an ependymoma. So a related tumor, but a different tumor. And so, this is an interesting case, and I think we're going to see more of these as we do more biopsy. Then also to look at other genetics, right? So we can sometimes, through liquid biopsy, we'll talk about this, figure out histone mutation status without biopsy. But what about the other genes? Those are really most easily assessed when you have a sample of the tumor. And that's because there are other drugs that don't target histone mutation or sort of experimental therapies where you really would like to know the status of these. And we'll talk a little bit about EGFR, we think plays an important role in predicting response to ONC201. So I think you just get a much more robust understanding of the tumor when you do a biopsy, because you can look for all the genes in that tumor and all the mutations that have occurred. And then finally, I think increasingly trials are going to have this phase 0. So phase 0 means is you give the drug and then you do the biopsy. So if you have a radiographic DIPG, you're going to be enrolled on drug X in this trial. Well, let's see if the drug gets into the tumor. So we'll give a dose, then do the biopsy. In addition to doing sequencing, we can also learn if the drug gets into your tumor. And I think that is going to be how we're going to really learn how these drugs, if they fail, is it because they failed because they didn't work or because they didn't actually get into the brainstem? So DIPG has not failed treatments because of physicians and scientists not trying. There have been upwards of 300 clinical trials that have been trying to improve upon radiation that really have failed to do that. And I think that's sort of the glasses half empty approach to that. The glasses half full is that we've used information from those trials as well as a huge explosion of information about the genetics of DIPG in the last 5 years, even new information coming out as recently as the last 5 months, to design the trials to be smarter and to build off the successes and failures. And we think that the trials that are being offered right now are for sure the most promising of that, long line of failed trials. I just want to talk about classes of trials. So epigenetics is a lecture in and of itself, but this histone mutation works in an epigenetic way. It means in how DNA is organized. And so because of that, a lot has been published on drugs that affect the epigenetics of cells. So if you look at these drugs, BET inhibitors, EZH2 inhibitors, HDAC inhibitors, this GSK-J4, these are drugs that are meant to rework the epigenetics of cells. And it's a heavy, detailed conversation. These will continue to get interest and be put into clinical trials. I'm not going to go into the details of those, but if you see, this is sort of a whole class of category of drugs, and they will likely be a part of DIPG therapy. I think there's a good chance of that, maybe in addition to other compounds. I think so far we don't have any real clinical data that any of these compounds by themselves is going to make a huge dent in DIPG, although obviously this research is ongoing. Convection enhanced delivery is a concept that is certainly of interest over the last 5-10 years. Dr. Sudane has pioneered a lot of this work out of New York and Cornell, where drugs are infused directly into the brainstem and the tumor, and the drugs are infused in a way that you can bypass that blood-brain barrier, which restricts so many drugs from getting into the brain. So these trials are ongoing, and in fact, there's a group in London that has been working on a sort of a 4-pronged catheter so that you could have multiple compounds, or I guess better put, you could have compounds going into multiple sites of the brainstem. I think that this is a real interesting and promising idea, and what we think of it as probably our best example, other than radiation, of local control. So it's going to get locally to that little patch that it infuses. Fortunately, there are some concerns that this doesn't get the leading edge, that infiltrative outside edge of DIPG that's going to grow into the rest of the brain. And what we've seen just anecdotally is a couple patients who have done okay on CED, but the tumor then starts to grow on the outside edge. And so I think the future of CAD may be best enhanced when you can do it plus a systemic therapy, almost the way the breast cancer is managed, where you have a local therapy, whether that's radiation or surgery, and then you have a systemic therapy. This is sort of a local therapy for a tumor that we know we really can't operate on. So here is, I think, where these are immune and molecular therapies that we're going to dig a little bit deeper in. And this is not a comprehensive list, but these are some compounds that we have seen some early anecdotal data of some promise. And I think we're going to see a lot more. And a lot of families are actively pursuing these trials. GDC-0084 is a drug from that is now called Paxlovid, coming from a drug company called Casia. Out of St. Jude, there's a trial that has shown some promise and definitely some CNS penetration. And I think what's interesting is some of the unpublished preclinical data is that this drug works even for DIPG cells that aren't having this PI3 kinase mutation, that maybe this is active in most DIPG cells, even when not mutant. And so I think this will be a part of the trials, and I think it's a promising trial if you're considering it. Out of Seattle and Stanford, they have a number of these CAR T cells, which is really building off the backbone of leukemia, where immune cells are, from the patient, are altered to go after a protein such as GD2. Just starting to get into the safety component of this. Obviously, a lot of promise. There's been a couple reports of adult GBM patients responding to this. I think there's some concerns about safety because of any kind of immune therapy causing swelling in the brainstem. So I think the investigators are going to go kind of low and slow and make sure that they have a good safety signal. ONC201 we'll talk about. There's a lot of interest and enthusiasm. We've done a lot of research on that. I do want to mention IDO inhibitors, so this drug indoximod, which has been mostly out of Theodore Johnson's lab at Georgia. The institutions down there have a couple phase 2s where indoximod is combined with temozolomide, and both in ependymoma and in DIPG, some early anecdotal reports both at some conferences and from some patients we've seen of doing a little better than expected. And so again, a promising trial that you guys may want to look into. And then finally, pembrolizumab, which is very important pathway for a lot of tumors, a lot of solid tumors, and so it is being studied in DIPG. I think the early reports are by itself, it's probably not going to be enough for DIPG, but maybe in combination. Just mention briefly CBD because it comes up so often in my clinic. So this is the non-psychoactive component of cannabis. It's a marijuana derivative. And CBD has been FDA approved as this compound Epidiolex for some seizure types. So we know it gets into the brain, and we now know that it's safe in children, at least in this form. And then there's a lot of studies and sort of off trial, outside of the clinic use of CBD for some symptoms that frequently come up in cancer: nausea, anxiety, pain. And I would say the field is not skeptical of this. I mean, I think it's skeptical of the fact that we don't know how to prescribe it or dose it. We don't really have dosing on that, but there is enough clinical use that there is probably some benefit to CBD in these symptoms. I think what our families are interested in is, does it work for treating the tumor? We know it penetrates the blood-brain barrier. There is some kind of very small amount of preclinical mouse and cells data that it works in GBM. What's interesting is that it knocks down a protein called ID1 that promotes tumor invasion. We know is active in ID1. And this is a project that my lab is looking into and is funded by a grant from the DIPG Collaborative. We just have been able to access CBD, and so we're going to look in to see how effective is it in DIPG cells at killing DIPG cells, knocking down ID1, and then does it work in mice? And hopefully be able to provide a rational framework for whether or not this should be brought into the clinic for our patients. Essentially, the bottom line is we need more study. We don't have clinical or dosing data. And, you know, it's probably safe, but I can tell you from the dozens of patients of mine that have taken it, I don't know that it's going to be a home run. I think if at anything, it might help other therapies for DIPG, but I think if you're a family that's, you know, really worried about missing out on this, I don't think that this, you know, especially with the kind of variability in the way that we can find it, not prescribed mostly through hospitals, it's not going to have a huge impact, but may help with some other symptoms and is probably safe. So let's talk about ONC201. And so ONC201 is an interesting drug because it's closest in class to an antipsychotic. Even though this drug itself has no psychiatric effects, it definitely gets into the brain, and it's been tested in a lot of different tumor cells and causes apoptosis, which is a fancy word for tumor cell death. What we know from the early data from its use in preclinical cell lines is that it can work in GBM cells. And in adults with GBM, it seems to get into the brain, but not work very well. What was interesting about those early trials is that some of the younger patients in that trial did have the histone mutation, and some of them did do better than expected. This was a patient, an early patient treated out in New York, who had sort of a sustained reduction in their DIPG. And we kind of, through this back clinical channel, realized this might have particular promise, not through some understanding of how this DRD2 antagonist, this dopamine receptor antagonist, would work. But we spent a lot of time in the last few years trying to sort this out. So this is a mouse model that we use in our lab. And again, this is a survival curve. And here's a mouse that we treated with just ONC201 here on the right. Tumor shrunk very small. And then here's a mouse that wasn't treated, and the tumor was growing very big. And our tumor model has this histone mutation, and the mice that were treated with ONC201 survived significantly longer. So to us, that was a big hit. We opened up the phase 1 trial here from Oncoceutics along with a couple other sites. This is led by Sharon Gardner at NYU. We were the 3rd or 4th site to open it up, and we've since enrolled 30 patients. So I just want to share our experience with the drug. I just want to take a brief side to talk about our center, which is named after Chad Carr. Chad Carr was a patient that I helped take care of here who had DIPG. And after he passed away, the family and the Department of Pediatrics here had sort of a Herculean effort to fundraise, and in just a short period of time raised enough money to name our Pediatric Brain Tumor Center after Chad. This has really vaulted our program, especially our focus on DIPG, just crazy acceleration. The number of clinicians and researchers working on it here has really exploded. And then just the number of patients being referred here. So it's a big focus of ours, but I really owe a lot to the folks, the Carr family and the folks here at U of M who have helped build this center and the infrastructure for all this research. So here's a patient with a DMG that came here who was diagnosed in 2018 and found to have the histone mutation. So again, just for context here, the average overall survival for a thalamic histone mutant tumor is 14 months. What we've seen from this patient treated just with ONC201 is that we're now over 2 years from diagnosis, and the tumor is at about 15% of its original size. Now, this is a patient that's doing particularly well. Not all of our patients are having this experience, especially our DIPGs, where we really don't see the tumor shrink as much as it does in the thalamus, even when the patient is responding. But just as a proof of principle, we really don't see these responses in K27M tumors to anything. So very promising of the potential here. This is more survival curves, and our current study is particularly focused on these thalamic patients. But just so you can see here, gray is our overall survival. You remember, the faster it dips down, the worse for these patients, the faster they have mortality from the tumor. That's this gray group. Our patients on ONC201, both recurrent and non-recurrent patients, doing much better than that, and really kind of unprecedented data. We're just starting to gather that data on brainstem patients. It is likely, from my analysis of it, better than historical controls, better than radiation by itself. Maybe not quite as compelling as the thalamus, and we just need a little bit more time to analyze that data. So how do we follow patients responding? So this was a paper that came out from Chetan Vedagowda's lab, where he showed that you could find DNA floating around in spinal fluid from adult GBMs and lower grade gliomas. And so we were interested over the last few years in figuring out if we could do that for DMG. What we did, this was a patient of mine with DIPG, and we were collecting spinal fluid from his ventricle, and we developed a test with that spinal fluid that we now believe is very sensitive for the histone mutation. So how is this helpful? So here's another patient with a different thalamic tumor who has had a response over time. And you see, here's the tumor over time shrinking. And then here at 3 time points, so the Oncoceutics trial allows us to collect spinal fluid every 2 months for certain patients. We see it starts here. This is the amount of K27M tumor DNA in the spinal fluid, bumps up here, but then by 6 months really rapidly drops off. And we think that that drop off predicts that longer term response. Again, here's our patient that we showed before. And now we've gotten a little better at actually following this tumor DNA in the plasma from patients. And I just want to be clear, this doesn't mean there are metastatic cells in the spinal fluid or plasma. It's just leaked out DNA, sort of waste material from cells that have died. Again, we see this patient who's had a good long response and the tumor DNA drops. And then can we use tumor DNA for diagnosis? So this is a patient of mine here, 15-year-old, who has a tumor that's a little lower than the PONS, so maybe a little atypical for DIPG. And the surgeon says, I'm happy to biopsy it, but I just want to let the family know, a little higher risk at this spot to biopsy from this spot. And maybe they may want to think twice due to the little bit higher risk than baseline for biopsying this region. Family says, well, we can get on the ONC201 trial without it. We're going to skip it at this point. What we do is we collect plasma from that patient as well as spinal fluid, and both of those were able to confirm for us that histone mutation without ever having to biopsy. Now, I should mention, these are research studies. This is not the same as getting an MRI or even an electrolyte check, where you have CLIA certification and you really can 100% feel good about your result. A research study, you have a little bit more, a little bit less rigor going into the verification and validity of the test. It still is in a sort of research setting. So we are getting these results and we're sharing them with family, but we're letting families know this is still a research test. And in the future, we would like to offer this, and a couple centers are getting a little closer to being able to offer this in the more normal clinical setting. So for the same patient, can we use tumor DNA to help guide clinical decisions? So this patient, this 15-year-old, had a tumor that, if you look at the tumor over time, it did grow to the point where by about a year, we were getting close to getting 25% bigger. This is the progressive disease. Family wasn't sure if it was progressive or not. So we started to follow the serum, this is actually plasma, allele fraction over time. And what we saw for her was a big bump at that around the same time. And again, it's a research test, but the family said, boy, you have 2 pieces of data telling us that this is growing. We would like to use a different therapy at this point. So I think this is the future. We're not like really, this is not being offered really outside of research settings, but this is the things that I think you'll get at an MRI appointment maybe a year or 2 from now, where you get your MRI and you get your plasma and maybe your spinal fluid tumor DNA result. Okay, just a few more slides here before I end. I just want to talk about our experience in how can we predict which patients might respond to ONC201. So we have a robust sequencing program here called MyOncoSeq, and we offer sequencing of the tumor to all of our patients who come. So this is the first 14 patients who came through our clinic that we sequenced. And this slide gets a little busy, but one thing that I'll tell you is, what we found is if tumors have low expression of this gene EGFR and this low gene FOXG1, those tumors seem to have later on the best response to ONC201. And conversely, if you have a high EGFR expression level or a mutation in EGFR, your tumor may only grow on ONC201. We're still learning out why that may be the case, but it does seem to hold true through a couple of different data sets. And so I'll just show you an example of a patient who unfortunately came here for the ONC201 trial and had an EGFR mutation. And this patient's tumor pretty early on grew metastases on ONC201 as well. The spinal fluid showed us that the tumor only went up. And so I think we're still confirming that this is the case, but I think in the future we'll be able to say, well, yes, you have a diffuse midline glioma, yes, you have a histone mutation, but what are the other things? And I'll just sort of say it again, we needed a biopsy to get this much information. What are the things in the biopsy that can tell you whether you have the fingerprint that's going to respond to this drug? Get a little smarter about who we put on what trial. I'll skip over this. This gets a little heavy. Okay, so where are we at with ONC201? It's safe in children. It gets into the brain. The early data is promising. Some children do experience exceptional responses, but many don't. So we're still figuring out the factors that predict this response. Having a tumor in the thalamus seems to predict a response. We have had patients in the brainstem who've had response, but less often than in the thalamus. Low EGFR expression. Starting treatment early seems to help, and an early tumor DNA response. And these are the questions we're asking in my lab. How important is the histone mutation? How important is the region? And then can combination therapy improve this? So just triggering along that, this is a massive group that's working on that question. So this is through a consortium called PNOC that's international and led by Sabine Mueller in Zurich. And what she's done is she and Javad Nazarian, also in Zurich, have assembled this team of clinicians and researchers who are working on Dmg Act, Diffuse Midline Glioma Adaptive Combinatorial Trial, to figure out what drugs can we add to ONC201 that might make these responses better. So if you think about how we beat leukemia, it was one drug worked pretty well, and we added a second and a third and a fourth. It was not until we got to 4 drugs that we made a response. So this is basically a platform trial that we are hopeful will open this fall at some sites, where you can get enrolled at any point, either pre-radiation or post-radiation or at relapse. And you'll get ONC201 to start, and then with another drug and maintenance. And right now, panobinostat is the one that we're going to add based on our early data that those 2 drugs might help work with each other. And then we also have about 10 or 12, this multi-site group is working on, that also seem to work with ONC201, and we're going to work with the drug companies to bring these in and quickly enroll and ask and answer questions about, does that combination work? We're going to ask that in 10 patients, and if it seems to have an early signal, then we're going to expand it to a larger group, and if it doesn't, we'll move on to the next. really adaptive so that we don't have to wait 10 years for the results. And between the 19 sites around the US and then internationally, we'll be able to accrue very quickly. So this is being worked on to open up hopefully in the fall. ONC206 is a newer cousin of ONC201 from Oncoceutics, which we think may actually work separately and synergistically with ONC201. So in Zurich, they're just about to open a phase 1 of ONC206, and then the idea is to bring it to all the PNOC sites as a combined arm with ONC201. I'll just end there. So this is the Dmg Act funding, the funds that have supported Dmg Act, Defeat DIPG, Chad Tough, and a number of others that have paid for the first year of this, but we still need funds for the years after that. And then this is just my lab and the folks that have supported my lab. These foundations are critical to all the work that we've done so far and been able to sort of keep up with this pace. And obviously the wonderful members of my lab and the collaborators. So I'll end there. I think I took a little bit too long, but I would love to stay on and answer any questions.
Keith, do you want to start with some questions, and then I'll do a couple of questions?
Yeah, you, Dr. Koschmann, you were talking obviously about the biopsy versus blood biopsy and everything else, and I had somebody sent me a question actually as you were going through that, having to deal with, we've gone from biopsy not being a standard of care to almost being a standard of care. And now we're getting questions on whether or not there were even some chances of kind of being misdiagnosed from the radiological reviews. And a lot of times it was an institution that may have not been as familiar with the IPGs. Are we now going back towards a blood biopsy as a standard of care at this point, or where do we land here on this?
To me, the future is going to be both. I don't think we're going to replace biopsy. And I think in part because there is information you learn from the tissue that's lost in the shuffle of the plasma. Let me give you an example. Let's say you pick up a PI3 kinase mutation, it's another gene that's mutated in the blood. You don't know if that mutation in the blood is in 10% of the tumor cells or 100%. And that's a really important question. It talks about the clonality. This DIPG, the cells are different throughout the various parts of the tumor. And one of the things you get from a biopsy is you learn which genes are mutated in all the cells and which ones are mutated in some of them. And obviously, a biopsy isn't perfect because it doesn't get to all the parts of the brain, but it's a lot better than the liquid samples that way. So you get a much more robust information. And I think this other question, we're going to get more and more savvy and I think increasingly safe. The biopsies are already safe, a lot safer than they were 5 years ago, and I think they're just going to get safer with these MRI ORs. And be able to learn things like, does the drug get into that patient's brain? If not, let's increase the dose or not use it, right? That's information you're just not going to get from a plasma. So the plasma, as well as the spinal fluid, I think will supplement the biopsy. So I think the future is both. And then obviously, it's a decision each family makes, and we certainly aren't going to hold it against a family that decides not to do a biopsy. There are some situations where the surgeon says this is a higher risk setting and we really wouldn't recommend it. Well, in those cases, you're just going to have to do what you can.
Well, and that also focuses on one of the things that we talked about at the DIPG symposium in 2019, and that was a session that dealt with whether or not there were these missed diagnoses. I wouldn't say misdiagnosed, but missed, as in, they missed the chance of it being DIPG or a PNET or something of that sort. And those numbers were high enough that it probably would make sense to have something to try to back that up, or at the very least, I think the way that we walked out of that was that any of the scans should be reviewed by an institution that has reviewed in the ballpark of about 15 to 20 DIPG cases per year. Otherwise, they may not know it. And that's the reason for and you cited it, but the International DIPG Registry has all of those are essentially reviewed. So anybody who participates in that gets that benefit.
Absolutely.
One of you also talked about some of the commonalities of DIPG and DMG, but also some of the differences of that. Do we see that there are more, or I guess, commonalities that we can deal with, whether it's a phase 1, a phase 2, phase 3? Do we see the translational research being tremendously different? I mean, where are these going to come together, I guess? Obviously, the support is there. If you look at the International DIPG Registry, it has now, it's now picking up DMGs. You look at, for example, the DIPG Collaborative, of which the Musella Foundation, Chad Tuff, Reflections of Grace, Cure Starts Now, Brooke Healy Foundation, Courage for Cures, all these organizations, a lot of the ones that you cite, are members of. We actually have also agreed to focus on DMGs. But other than the funding channel and other than the researchers being the same, do we see the trials being completely separate though? Or are they going to be common and translational but not in clinical?
So I think these are bigger, longer standing questions. You know, for sure, I remember, you know, going to conferences as I was just leaving training, hosted by the DIPG Collaborative, and some of these brain tumor conferences, that it was very clear that the paradigm was not working, that something worked in a mouse or it worked in other cancers, and then we'll bring it to DIPG, and 2 or 3 years later, we'll have an answer. And, you know, I think that paradigm has quickly been replaced by a much higher bar for opening a trial in DIPG. And not only that, there is some competitiveness, which is good for the field, right? So there's enough trials that are open now that we now know that if it's not a trial that's gained some traction, either through some early responses from patients or really compelling preclinical data, just a really enthusiastic response amongst the research community, it's probably not going to fill up. And I think the word of mouth now by families, where families are now more connected than the clinicians and scientists, which are very connected, but the families are so connected that when there is momentum for a treatment, it moves quick in a good way. You get to that promising treatment. That's the experience we've had with ONC201. Get a lot of patients on it. You quickly answer whether there's enough promise there. So I think that through all these channels, through social media, support groups, through the research community being better informed and better equipped to ask and answer questions, better models. And then the final piece is we need new trial designs. And we're starting to see that with Dmg Act and some other trials where you're not going to sit around and accrue 30 or 40 patients on a phase 1 and then, you know, think about that for a few years. You're going to want these quick new adaptive models, and they're going to be based not just on how the patient does, but what's happening in that patient's samples, in the biopsy that was taken after they got the drug, or in the spinal fluid or in the plasma, and you're going to synthesize all that in real time and quickly pitch that drug out or expand it if it's working. And then once we get those hits, like I believe that ONC201 is an early hit, adding drugs on top of it. And so I think between all these things, I do think we are in the midst of shaking this thing up and finally breaking this thing open.
One other question, and then I'll toss it back over to Al here. Obviously you talked a little bit about DMGs and you talk about the kind of the way that these tumors can change and be different depending upon where you're taking any type of samples on this. There's also been a huge wave of research that are really focusing on the plasticity of these cells. How do you think that relates to this? Does it relate more to DIPG or to DMGs? You know, I know that at the symposiums it was the topic that everybody was really focusing on, was this idea that it is a changing tumor effectively.
Yeah, I think it is. I mean, I think we've learned that any study in high-grade glioma, whether that be DIPG, DMG, or GBM, peds or adult, shows that that is one of the tools that high-grade gliomas have, which is adaptability. And I think radiation is really helpful, but it also stirs up things and irritates the DNA to mutate. The cells that survive that radiation maybe come out of it just as strong or stronger. And so it is an argument. if biopsying DIPG was as safe as a blood draw, for sure the field would be ready to do it before radiation, after radiation, maybe every 3 months to get at that question. What has changed about the tumor? Is it a completely new tumor molecularly that we want to adjust our therapies? One thing I will say, the tumors that we've sequenced here and some other sites have sequenced, diagnosis to autopsy, they still hold on to their most important genes. So that histone mutation doesn't go away. Some of the big ones that we're going to target don't go away. You may pick up some extra bad actors, but if you target your drugs to H3K27M or some of those big early clonal mutations, probably they're still there at autopsy. So, I mean, I don't think we have to be too concerned that we're losing those, just that they're maybe picking up some other tools. Liquid biopsy can help with that, but again, liquid biopsy does best at following ones that you know, and does a little worse at telling you really robust information about an unsampled tumor.
Okay, let me ask a couple of questions. The first few are on UNC201. You showed a couple of graphs where the tumors got worse for the first 100 days and then they got better. Is that a common pattern? Because what I've seen is people have a worse first or second scan and they give up and they stop and they go on to something else. So they might be stopping too soon.
I think that's true. I think we are enriched on the pediatric side with in the clinical trial, not the compassionate use. So the clinical trial has a lot of these patients who start early. They start at diagnosis or they start right after their first radiation. Those patients have plenty of time for the drug to work. And what happens, we know there's this phenomenon that in the first 1 to 5 months, sometimes the tumor grows and we ride it out. We tell the families, this is probably not progression. This is the tumor swelling, pseudo-progression from the radiation. And it's easier for us to ride that out for these early patients because we say, well, it's a little early for progression. Let's see how this goes. So that's what we did with this patient. We said, here you are at day 105. Tumor was bigger, a little bigger, but didn't look like there were new spots in the brain where it had grown. And it's the right time for pseudo-progression. Let's keep going. It's different case in our patients who have had relapse. Those tumors are so quick to grow again after that relapse that it may be the right call if it grows yet again to say, we really need to try something other than UNC201 because we don't have that kind of time or confidence that it's that pseudo-progression. And then expanded access is mostly those patients that are relapsed. We do have patients who have had relapsed tumors who have responded. So I don't want to say that doesn't have promise in that setting, but usually what I'll say is we really want to get these patients radiated before they start on 201 and or any targeted therapy for that matter. Just put the brakes on the tumor with the thing that we know that works and give the time for that drug to work a little bit, if that makes sense.
That makes a lot of sense. That's how it should be. The next question is a nice one. We have somebody who's on the trial for almost 2 years, and she asks, when do you stop on 201? What is the plan? Do you just go on forever?
Yeah. Well, we're in uncharted territories, right? It doesn't come up all that often in high-grade glioma that we're asking that, but it's an important question to ask. I think UNC201 is a drug that happens to have low toxicity. Our patients mostly don't seem to have side effects. It's not like a typical chemotherapy from that end. Now, that being said, we don't know about its long-term side effects. We're in kind of new era where patients will be taking it, and maybe that 5 to 10 years down the road, if we get patients living that long, that there may be some secondary side effects. I think for most of our patients who are getting a response and they're tolerating the drug, I'm not talking them out of taking the drug. Some of the other GBMs, non-midline tumors that have gotten to that 4 or 5 years for whatever treatment, that's about where I'll start to say, listen, I don't know that the drug is doing much. If it's 4 to 5 years, the tumor probably would have grown by now. This might be a time where we're going to go ahead and try you off and see how it goes. But it may be for this patient who seems to be one of the patients who's doing well, waiting till closer to 3, 4, maybe even 5 years if it's still going well. Because as long as they're tolerating it, we really don't want to let up on this tumor, which is so aggressive.
Okay, and you showed another chart that said people who have the EGFR mutations do worse. What about combining an anti-EGFR agent with UNC201 just on everybody to cover all bases? Would that make sense?
It would make a lot of sense. And I think our group and Dr. Nazarian's group, who have this kind of early data, are working on that concept. And we'll see if that is promising or not. Especially, I think, if we have a patient like these patients down at the bottom who had very high EGFR, and we know the drug, maybe it's the drug they want to get on, but we have less hope that the drug's going to work. That combination may be most promising. I think the trial design is not there for that kind of adaptability. We'll have to get even more creative, and I think the right time to do it would be early and not late. So I think we're putting the accelerator on those studies, Al, in terms of combining it with EGFR inhibitors, combining it with other markers of resistance, and learning which ones work and in which cell types, and then bringing that to the clinic. But we're probably still, at least a year or two away from that.
Okay. This is a strange question. Why won't the FDA just approve something like UNC201? What would be the harm in letting people just get it who need it? At what point do you say, if you have such a small group of people, how much proof do you need that it is safe and it actually works?
Yeah, it's not really an area that I have a ton of expertise in, other than watching some of these drugs with early promise really struggle to get across that finish line of FDA approval. And it's interesting because if you look at the trials that do seem much less compelling to me in adult tumors, get to FDA approval very quick. And I think part of that is those trials are able to accrue very quickly high numbers of patients, hundreds and thousands, because breast cancer and GBM and lung cancer, just much more number of people that develop that condition. And then also that those trials are often by drug companies that have a huge amount of resources. The biggest drug companies do have the funds to get the data and the whatever else you need to get a drug FDA approved. And it's harder for a startup drug company, which really needs to fundraise, crowdsource to get the funds to get across that finish line. It would make our lives easier in the clinic. And I do think that this drug has a use outside of the clinical trial in an FDA approved setting, for patients who just don't meet the criteria. Now, that being said, we learn a lot from clinical trials. And so the benefit of clinical trials alongside or before FDA approval is clearly there. That's how we keep up the rigor and the statistics and the trial population to be not heterogeneous and to be able to really say, does the drug work or not, right? So there is a time and a place for the FDA approval, but I think that there is a precedent for some drugs showing this much promise in the phase 1 setting to get to an FDA approval. So we'll see if they can do that.
I got 3 more questions and then I'll go back to Keith. Is the H3K27M mutation found in any other tumors?
No, essentially no. It's brain tumors, and really it's brain tumors in young patients in the midline. We essentially don't see it outside of the midline, of just a few cases of that, but those are all high-grade gliomas. There are a couple other histone mutations that do show up in some other solid tumors in the body, but they're in other locations of that histone tail. Mm-hmm. So,
okay.
G34, G36 in some other solid tumor.
Okay, what about using proton radiation? Is there any benefit to that over standard radiation?
That's a good question. The proton is increasingly available. I think we now know that it's safe, and there's certainly a role for it for some tumors. So for medulloblastoma, I think proton is increasingly a standard of care for the craniospinal because you can do it in a way that reduces risk to important centers. The hypothalamus and the pituitary gland, the hearing structures, the heart, the lungs. The proton can really tighten the field up around the brain and spine and reduce those risks. Because a lot of those patients do have longer term survival, you are really not wanting to hit those structures. DIPG, we just unfortunately don't have the patients surviving long enough to get those potential benefits. And I think some of the early data on proton, there was some real concern that in the brainstem, proton could be less safe. I think at the big centers, that concern is really dissipated. They've shown that it's safe. What I tell my families is proton and photon work just as well. If your main center that you're already going to, that you're comfortable with, that's closest to home, whatever the factors are, is recommending one or the other, and just go with that, and don't necessarily travel for it. We just haven't figured out the benefit yet. It's not worth traveling for proton.
But if we have, sorry, Carl, if I may, want to ask follow up on that one. As we start to have more centers start to look at reirradiation, do we find that proton now may make some sense at the initial treatment?
Well, it's interesting you say that. I had a patient last week that we were going to reirradiate, and they had gotten proton to start at an outside center. And we talked to that radiation oncologist. And at least in that case, they said, I don't feel comfortable using proton twice. Now, I don't know if that is going to be the case across centers, if that risk remains. I think that photon is safe to give as a second radiation. That's what most of this data is based on. And so I don't think that proton opens or closes your door to reirradiation, but it may close your door to reirradiation with proton, if that makes sense.
Okay, my last question. How closely do the mouse models reflect reality in the kids? In other words, did you see anything that works super spectacular in mice, and then when you try it on the kids, it doesn't work?
Yeah, for sure. I mean, I think a lot of those 300 trials had really positive. I think panobinostat is one where the mouse data was pretty good, and at least so far, the clinical data has been that we just mostly anecdotally from a lot of patients getting treated with panobinostat off trial, not a lot of reports of responses. I think that drug may be very useful in the combination setting, as we talked about. But what are the differences? You know, I think the blood-brain barrier is a little different. I think that the ability to really recapitulate what we do to the patients in terms of biopsy or not, radiation or not. If it's a model where we had to implant cells into the brainstem, well, we've just disrupted the blood-brain barrier dramatically. And so I think the mouse data is what it is. It's definitely better than cell data, and it definitely helps. We use it to this day. We certainly rely on it, but there is a big leap from mouse to human.
Okay, I just got one more. I'm sorry, Keith. It just came in. What about not doing radiotherapy and just trying something like UNC201 or one of the other trials? Or does it just go so fast that you have to do the radiation and knock it down?
Got to do radiation. You know, I mean, I think there may be a patient where the family says, listen, you're telling us this prognosis is this bad. It's going to require us to drive really far from home or some resource issue to get to radiation. We just want to spend the time that we have not feeling like a patient. And radiation is going to really double that survival or more, you know, from 3 to 6 months to closer to 12 plus months. And so if the families have sometimes made that decisions in our clinic, a minority, UNC201 is really, I mean, any experimental trial is really going to need to build off the backbone of that radiation.
Okay, that's it for my questions. Keith, you could ask 2 or 3 more, and then we have to wrap it up.
Yeah, I have exactly 3 the clarifications or questions on it. One of which was, Al, you had mentioned the FDA issue, and obviously that's top of mind. I would encourage everybody to follow with what the Musella Foundation is doing, also with the DIPG Collaborative and Cure Starts Now, because we're going to be talking a little bit more about that here in the next week, and that's kind of what Al was talking about. So I guess I'll leave it at that, Al, unless you can think of anything else. It's called a Promising Pathway Act.
Well, I just wanted to add one thing, in response to what Cole said. I think once we get FDA approval, the research is not going to stop. We're going to follow all the kids in a registry, like probably DIPG registry, or I run a registry also. And we'll be able to try all the different combinations, and every single kid would be in trials basically, instead of just a select few. And you guys will be free to think up the combinations and just try them.
Exactly.
It gets rid of a lot of these barriers.
and a lot of your registries are coming together. For example, you have the International DIPG Registry, which is the DIPG DMG Registry, which is the biggest of all of them out there. Has 114 institutions, but it's also coming together with a lot of the things that are going on in Europe for the SIOP Registry, and it has a ton of data in it. So, I mean, as these start to come together, I think it's going to provide a great resource to families that are going through these treatments. Carl, you mentioned the Hoffman JCO paper, also from the DIPG registry, that deals with statistics that may increase or may create survivability within DIPG. One of the ones that we constantly get asked about is also the age. We see, and some of them make a lot of sense other than that. I mean, for example, you talk about fewer symptoms at diagnosis, smaller tumors on MRI with little to no extension beyond the pons, and the H3 K27 mutation. But the one is age, and that is that if the child is younger than 3 or older than 10. And we also are starting to see some of the very older patients that have different survival times as well. Can you comment to that at all, or what's your gut say about that?
Yeah, I think the rare patients that are over 20, if you talk to our adult colleagues who are a little bit sometimes less clued into the DIPG world, and they'll say, well, I got a patient I've been following for 3+ years, and I'm certain it's a DIPG, and that's obviously so rarely the case in a patient who's 5 to 10 years old. I don't know. I mean, I think we know that the histone mutation is going to land in that 5 to 10 group mostly. So when you look at plot A here, which is kind of agnostic of histone, now obviously this was the most rigorous look at MRI-defined DIPG, but if you look here, probably it was these non-3 to 10-year-olds that were enriched for non-histone. Now, that being said, I think for a true DIPG, I think this study and a couple other studies have sort of showed that if it really passes that rigorous radiology assessment and as a DIPG, that histone mutation isn't as critical for survival. Those patients are going to have a tough prognosis regardless. But I think you're starting to look at not that textbook worst case, it's sort of the most common story of DIPG is a 5 to 10-year-old with a histone mutation. Once you get out of that range, the microenvironment, the developmental environment start to have other factors that maybe influenced it to just be a little less aggressive. We still don't know exactly what those biological differences are, but I feel like the 5 to 10-year-old pons is the most receptive to just turning on a tumor when you pick up that mutation.
Yeah. No, and we're starting to follow within the DIPG registry a huge amount of older patients, and I think historically we've looked at DIPG and DMGs as nothing but children. And as we start to see more and more adults in this, it really changes the way that we define some of these factors. I mean, right now we're looking at, I want to say we have, I think it's about, just in the United States here, I think we just crested over 1,100 patients that are in the registry. And that not only is a great way to be able to look at data, but it's also a really good resource for families because you can kind of get that second reading of that MRI as well. The only other thing that I was going to make sure parents are aware of is sometimes within the DIPG community, and I get this because I've been in this community for now 13 years, we tend to really look at certain drugs and really get caught up in it and think that that is everything with it. And I've learned over the years to also look at many other trials at the same time. And whether you have DIPG or DMG, one of the things that I would highly stress is for parents to look at all open trials and talk with their doctor about what trials make sense for them. Resources that you can use are going to be virtual trials, clinicaltrials.gov, also DIPG.org. If you want something specific to DIPG and DMG, you can simply go to that website and it will actually tell you on a daily basis what trials have opened, what trials are closed, in US, Canada, Europe, New Zealand, and even it's given private pharmaceutical trials like the early or expanded access program by ONC 201. So you can see what may apply for you, because if you may not have DIPG, it may not be the ones you're looking at. So we're trying to find something that fits for you guys as well. But look at everything, because there's lots of other trials out there as well that are having some pretty interesting results as well that we're seeing. So that's all I got.
Okay, thank you very much for joining us. This was an excellent presentation. I just want to talk about next week's webinar. Next Sunday night, we have Dr. Santosh Kesari, who is the Director of Neuro-Oncology at the Pacific Neuroscience Institute, talking about innovative clinical trials in brain tumors. He's working with a lot of new trials, including the CAR T cells, which should be very interesting. And we'll see you next week. Thank you very much. Bye-bye.